Avatar, founder of Suman Kidney Foundation and Utkarsh Kidney Hospital, Aurangabad. He's a consultant nephrologist and transplant physician, and probably has got highest number of transplant experience in the region. He has an experience of around 1230 kidney transplants so far. So I would like to invite Dr. Suhas Bhavekar to highlight acute allograft rejection.
Thank you. Thank you, Dr. Oswal, for this invitation. He's the witness to majority of those cases. He's one surgeon. At the outset, I would like to thank organizing committee members for this invitation. I'm humbled and excited, humbled to see my teachers, senior urologists in this hall, and excited to share my experience over the last 32 years of managing those 40 transplants of acute allograft rejection. So the incidence of 1 year acute allograft rejection over a period of time with the addition of newer immunosuppressive medications is decreasing. It was 80% in 1965 and dropped to 50% in 1985 with mercaptopurines, radiation therapy, prednisolone and ADGAM. This further dropped from 50% to 15% over next 20 years between 1985 to 2005 with advent of unmodified cyclosporine and monoclonal OKT3, modified cyclosporine, Sandimmune and Nuorol, and then tacrolimus, MMF, thymoglobulin and basiliximab. Further reduction in the incidence of acute allograft rejection was observed from 2005 to till date, from 15% to less than 10% now, with the advent of belatacept, everolimus, sirolimus, and mycophenolic acid, rituximab. So the signs of hyperacute rejection in first 48 hours are on table. One can see dusky blue patchy kidneys if the rejection is immediate, and if it happens after some hours, the kidney, the person can develop high fever and tender graft, thrombosis of the graft, no perfusion, and a need to remove the organ to reduce the signs and symptoms. Acute allograft rejection can present after 1 week to 2 years anytime with high fever, again more than 100 degrees Fahrenheit. Then flu-like symptoms, fluid retention, increase in urea, creatinine, oliguria, tenderness of the graft, and chronic rejection evolves gradually over months or years with creeping creatinine syndrome and fluctuating albumin creatinine ratio, anemia and fatigability. So in early period or early phase of transplants worldwide, the acute allograft rejections were classified into steroid responsive and steroid non-responsive. Later on, this classification was extended to hyperacute rejection, acute accelerated rejection, and then chronic rejection. Till 2001, when BAMF reclassified acute allograft rejection into T-cell mediated and antibody mediated rejections. The evolution of BAMF process in classifying rejection is ongoing with the advent of newer tools like artificial intelligence, molecular microscope, molecular classifiers, and then many other gene transcript studies. So the risk of acute rejection in any patient has got many variables. The most influential variable is anti-HLA sensitization of the recipient, mostly due to previous transplants, multiple blood transfusions, multiple pregnancies. Younger the recipient, older the donor, the risk of acute rejection is higher. In cadaver transplants, primary delayed graft function increases the risk of acute allograft rejection. The factors which may be considered as increasing acute rejection but they have no influence are the concomitant infections, HCV, HIV positivity, or HBV positivity, or associated diseases, diabetes, hypertension, ischemic heart disease, Recipient's body mass or recipient's gender has no influence at all on incidence of acute rejection. The predictors of acute allograft rejection pre-transplant are donor-specific antibodies, preformed antibodies, and HLA-A-B-DR mismatch between the donor and recipient. If these recipients are under immunosuppressed, they are likely to develop de novo donor-specific antibodies, and the risk goes up. In post-transplant, the predictors are the immunosuppressive protocol used by the center and the non-adherence by the recipient for that protocol, that particular protocol, and the pharmacogenomics or genetics of that particular drug for that particular patient pertaining to pharmacokinetics and pharmacodynamics of the drug per se. So, when to biopsy a patient with for acute allograft rejection? The answer to that question is biopsy when in doubt, or when the biopsy is feasible. The indications mostly are acute unexplained deterioration in the graft function, excluding the surgical causes and pre-renal causes. And then recently, for some situations, biomarkers of rejection are being studied in Western literature, and they can be the indication of biopsy if they are positive. Next question is, which part of the nephron is affected is important. Knowing that which part of the nephron is affected is very important for understanding the cause of rejection, then severity of rejection, and then type of rejection and treatment indicated. So there are 4 compartments in the, which are important: glomerulus, tubules, interstitium, and vessels. So if someone has tubules involved, then it is T-cell mediated rejection. Tubules and interstitium involved, then it becomes little severe T-cell mediated rejection. If the arteries, glomerular capillary bed and peritubular capillary bed is involved, then it is antibody mediated rejection. So knowing which part of the nephron is affected will guide you about the mechanism, the cause of rejection. And then the severity, again the extent of inflammation, the total inflammation score of the graft, and iBox pattern scores of the graft, again they will guide you for the therapy. The treatment, the T-cell mediated rejection is treated, we'll look into that next slide. So where to look for the rejection? Again, the in the tubules, the tubular cells and the basement membrane, the lymphocytes in between that is seen in the first A picture, and that is T-cell mediated rejection, 1A. Then if the interstitium is infiltrated with a lot of cells, then it is 1B in addition to tubulitis. And then the third C slide is showing you the inflammation in the intima of the arteries, and that is BAMF2A, T-cell mediated rejection. The D picture is showing you the peritubular capillary infiltration of T cells, and that is due to antibody mediated rejection. And then E picture is showing you the C4D staining along the peritubular capillaries with the immunohistochemistry stain. Then this BAMF 2017 was the main year for histopathological classification for T-cell mediated and antibody mediated rejection into class 1, class 2 and class 3 for T-cell mediated rejection. So we all know in this hall about details of that. 1A indicates only tubules being involved. 1B indicates tubules and interstitium. Then class 2, antibody mediated and cell mediated, you have to add thymoglobin in addition. AKI, if biopsy is not feasible, then pulse steroid is to be given, and if AKI resolves, well and good, just monitor the graft and optimize the immunosuppression. If DSA is positive, then biopsy is indicated. If AKI doesn't resolve, then give this, if DSA is positive, combination of RPI, rituximab plasmapheresis IVIG, and thymoglobin is used empirically. If DSA is negative, only thymoglobulin is used. So thank you very much.